Hello, and welcome to this episode of The Forefront, supporting mealtime insulin management for children with diabetes. My name is Jody Lavin-Tompkins, and I'm a nurse, certified diabetes care and education specialist, and director of accreditation and content development at the Association of Diabetes Care and Education Specialists. Joining me today is Traci Carter, a pediatric diabetes nurse, care and education specialist at Walter Reed National Military Medical Center in Bethesda, Maryland. She was a volunteer on the Virginia Diabetes Council and helped with the Diabetes in Schools grant project called LEARNS, which provided continuing education in diabetes to school nurses across the state. We're excited to have her here with us today. With the support of Lily, the purpose of today's discussion is to assess for challenges of diabetes management in the pediatric population and distinguish mealtime insulin options for children with diabetes. Welcome, Traci.
Thank you. Thank you for including me today.
So I want to start off today's discussion with the guidelines for glycemic management in children with diabetes, because I, for one, did not take care of children, and I'm sure some of our listeners need a refresher on that. So could you go over those guidelines for us?
Yes, let's do that. It is very important with children with diabetes to avoid chronic hyperglycemia and wide glucose fluctuations during years of rapid brain development and growth of the child. So glycemic guidelines also include avoidance of hypoglycemia in diabetes care. And the International Society for Pediatric and Adolescent Diabetes, or ISPAD, published the recommendations in 2018 for a less than 7% A1C for those receiving comprehensive care. And at the time of this recording, these are being updated but have not yet been published. And you are also familiar, I'm sure, with the ADA, or American Diabetes Association, standards of care that are published. And in 2022, of course, the A1C goals are recommended to be assessed and individualized with the child's provider, preferably under 7% for most children, but under 6.5% is reserved for children who can safely reach it without significant hypoglycemia, such as those who are in the honeymoon period, early in their diagnosis, or those with well-rounded support team. This team would include specialized healthcare providers, well-trained parents and guardians, school personnel, and of course, I would advocate for diabetes care and education specialists. Also, the ADA standards state that it is uncertain what the time and range goals should be, but I know we're all becoming more familiar with that with CGMs. And it should be more personalized for children and toddlers until those further studies are done that are needed.
Okay, so thank you for that review of the guidelines. And I'm sure that there might be some challenges in trying to meet these guidelines, especially in the pediatric population. So I think our listeners would be interested in some of the challenges that you see that children encounter in trying to meet the guidelines that may impact their efforts to optimize their glycemic management.
Yes, in caring for children with diabetes, we do see many challenges that impact their care. And in particular, at school or in after-school programs, in sports, we advocate for children with diabetes, according to standards of care, to have at least 60 minutes of physical activity. This means that they're going to need to increase monitoring, adjust food intake, and of course, insulin doses before and after or as needed related to that activity. So we're going to provide extra support with that. We're going to also consider spending the night away from home-trained adults and have to consider what that means, that if they're going to be with grandparents or friends of the family or school friends and their families, they're going to need adequate supplies also, and make sure that they're in a safe environment, as well as all the other things that can impact them when they come in for their appointments. We're considering hormone changes and growth spurts. We're looking at those growth charts. And all of those things can mean that doses need changed at regular intervals. They could be chasing highs and lows, but regular follow-ups with the healthcare team is essential to maintain that goal A1C And so shared data is important for proper dose adjustments, and this can be made as needed. So this can also avoid the family needing to have that snacking and stacking with the chasing with the carbohydrates or the insulin dosing. We also see children facing the stigma surrounding diabetes, and we don't want them to be different from other children. We want them to live their lives, and hopefully the healthcare team can help them utilize are the tools that we have on hand are things like screening tools to identify eating disorders or depression screenings, which are standards of care, and they help facilitate communication between providers and families and the children to identify these concerns. Other coping tools that we utilize with our parents and children are scripting techniques so that children are prepared to talk to their peers about what diabetes is and how they cope from day to day. And we think this empowers them to interact with their peers and not make it so much of a stigma around life with diabetes. Children of all ages face these challenges when they're inconsistent eaters, but especially the little ones. Luckily, with today's therapies, we may discuss when they want to eat, not just what they want to eat. So they can still have their favorite foods and some flexibility. I do worry if they need to plan ahead of meals to give doses for insulin action times, and especially if the meal is delayed. They may have hypoglycemia and fear if it's given too early. On the other hand, if school lunch doses prove to be a challenge, that can also impact whether or not they have good A1C coverage and good outcomes with their diabetes management. And I can't help but think of a story with one child in particular who told me that he barely got any time to eat his lunch because he was expected to leave his class early, go down to his school nurse, get his blood sugar checked or his CGM, and then go down and stand in the lunch line, get his tray, have his carbs counted, eat, and then figure out how many carbs he actually ate, have those counted, do the ratios, give his insulin, and then go back to his class after all of this. And then he was ending up missing class time before and after the lunch meal. So all of this hurry, maybe he didn't even finish all of the carbohydrates they had anticipated. He may not have been able to cover everything and then ends up later treating lows. So his day was disrupted quite a bit by either having to be pulled for snacks or not getting adequate amount of insulin through the day. And so that was a struggle to hear what he was going through just to have lunch in the middle of a school day.
It makes sense that a lot of the challenges seem to be around food intake. So can you take a minute to talk about mealtime insulins and how they've evolved to potentially address these challenges? And I want to make sure the audience knows that for the purposes of this discussion, fast-acting insulins containing excipients that result in the absorption of the insulin to be faster will be referred to as faster-acting insulins, keeping in mind this is not a new class of insulins.
Yes. Thankfully, we do have more choices now with mealtime insulins, and excipients added to make faster-acting insulins can be dosed at the start of the meal or within 20 minutes after starting the meal. More precise dosing and less chasing blood glucose numbers with snacking and reacting. So this mealtime insulin, also referred to as bolus or rapid-acting, can help with this example that I gave with the school nurse trying to help this student get to the lunch line and back to class in time. So mealtime scheduled dosing timing provides for more flexibility. And really the role of mealtime insulin is to cover those carbohydrates right when you want to eat them and give you some lifestyle flexibility. And then also to correct that high blood glucose.
So you mentioned the faster acting mealtime insulins. Could you outline the benefits and risks of these for us?
Yes, there are benefits of the newer faster acting mealtime insulins. In addition to what we've already discussed, there are some interesting data that suggests faster acting insulins reduce postprandial spikes. However, larger, more powered studies are needed to confirm. The onset of action and duration of action should match the glucose spike. Also, there's a potential for avoidance of insulin stacking. This is especially important for parents who see that rise in the CGM and want to chase those high blood sugars. The risks, as we see with all of these products, you may see injection infusion site reactions, and you may not want to change insulin for a child who is already adequately managed. As with any insulin change, the plan for increasing glucose monitoring and hypoglycemia prevention treatment is important, and you need to have rescue medication treatments available.
So, Traci, based on your personal experience and considering the risks and benefits you just discussed, who do you think might benefit the most from these newer mealtime insulin options?
What I've seen is the children who are more likely to be inconsistent eaters, unpredictable meal finishers, and especially when they're outside of the home and they're having unfamiliar meals, something that's unusual at a restaurant or at a friend's house. And also if portion sizes are going to vary and you're trying to count carbs and you're not sure if they're going to finish the whole portion that's being served to them, that can be difficult. So there's opportunities for allowing dosing after they see what they actually are going to eat, and you have a better idea of the carbohydrate content of that recipe or that meal. So it may reduce the postprandial blood glucose spikes and provide better personalized targets. There's also the challenge of giving insulin based on its indicated dosing time because eating time may be delayed or interrupted. What I think of with this is on sick days, just really having a hard time predicting, when they're going to feel like they're going to start that meal, or if they're not going to feel like going ahead and eating, or if they're traveling and meal times aren't on a regular basis, or even staying with friends because they get distracted and want to go out and play. And so it allows for dosing when the meal is in front of them and ready. Also, with the challenge of high postprandial glucoses after meals, this is more likely to match the insulin onset of action and the glucose spike that we see on CGMs, now that we're learning so much about blood glucose patterns with the ability to watch it in real time on CGMs.
Well, Traci, this has been really informative, and I'm wondering if you have any closing thoughts you'd like to share with our audience.
Yes, well, thank you. I really think in consideration when transitioning from one mealtime insulin to another, we need to think about patients on insulin pumps. And I always look up first to see if those new insulins are approved for a particular pump. So I would talk to the healthcare provider about that also, and monitor regularly for dose changes, adverse events, talk through that with their parent or guardian. And then I also recommend regular follow-up with the healthcare team to see how they're responding to the new therapies.
Traci, thank you so much for taking the time to join us for this episode of The Forefront and sharing your knowledge and experiences with our audience. As a diabetes care and education specialist, I know how useful this information is for clinical practice. So I'm sure our viewers really appreciate hearing your firsthand experience.
Thank you. Thank you for including me today.
We also want to thank our sponsor, Lilly, once again for their support of this episode of The Forefront. Thank you for watching, and please join us again for future episodes.